Welcome everyone to the bar tonight. We get to welcome back Dr. Jeff Kindred to clear up everything from tendonitis to tendon ruptures, everything in between. Let's go. To quote the great philosopher, Chancellor Bennett from 79th, this is our first We Back episode.
We back, and 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 we back.
What's up,
Hey,
Dr. Kindred? Welcome back, man.
Good to be with you.
Man, so glad to have you. What are you drinking tonight?
Oh, I went crazy tonight. This isn't a 44 ouncer, but it is a Pepsi Zero. Now, let me tell you something. Pepsi Zero on its own is like a 3 or 4. You squeeze some fresh lime in it though, and you got yourself like an 8 or a 9.
Ooh.
If you haven't done that, give it a try. I converted one of my partners to doing that, and he brings limes to work now.
No kidding. I wouldn't have even thought of that as an option, but I feel like that, did they come out with a product, or at least maybe Sonic hits that? They never did?
They came out with the lime, but it's like artificial lime. You got to get fresh lime.
Got it.
And Diet Coke or Diet Pepsi, I don't discriminate. Some people are snobs, cola snobs. I'm not. But I do prefer Pepsi over Coke.
So you went with the Zero product though. Have you had Coke Zero though?
Yeah, I do. I sometimes I like the Zero, sometimes I like the Diet. It just depends.
Yeah. I guess in my world of Coke Zero for sure. I didn't even think it was a competition. So seeing somebody drink a Pepsi Zero does at least explain how they stay in business with the product, but at least somebody drinks it. Jeff's got to keep it down. But
so do you discriminate between Coke Zero and Diet Coke though, or is it one or the other?
Definitely dramatic difference.
Okay.
The side by side's not even close. The Coke Zero is just the right amount of sweetness. I don't know if it's my palate, if it's just my taste buds. You know, we did the 23andMe where you look at all the different markers and will they taste bitter? Will they not? Do they, smell asparagus when they pee? All the different genetic factors.
Yeah.
And mine was definitely not the one that has an astute palate. So maybe in my simpleton mind, I'm Coke Zero guy.
Okay, put lime in it. You got to do this. You got to get fresh lime, squeeze in either Diet Coke or Coke Zero. It makes Diet Coke taste a lot better actually than normal Diet Coke.
What's the ratio?
Coke Zero's good too.
A whole lime?
No, just a slice. Just get a slice of it. Maybe an eighth of it. Squeeze it in there.
Well, I feel like this is punishment round 2. Last time, the drink that I had that's blindsided me was the lemon drop. I did not enjoy the lemon drop. There was nothing fun about the lemon drop that I had a few weeks back. But this is called the Chocomole, and I've actually never tasted it before, but there's a lot of things in it. Catch the TikTok and the Instagram story to catch what's in this thing. But I believe my wife thought that this sounded very good. But from my understanding, the reviews have not been good. I think I'm supposed to know that answer, Jeff. I think I'm supposed to know what's in this. There's something.
She makes it and you drink it. Huh? No questions asked.
We actually made it on video, and I still don't know this answer. There's something chocolatey. God, I don't know. I don't got anything. But let me taste it real quick. Let's see. Oh, okay. Yeah, I know exactly what's in that now. That is not good. That is chocolate. Tastes like a vodka, and that is definitely a spice. Our producer has corrected me. It is tequila that is in there. And that is definitely a Chipotle-like spice with like a chocolate. So that's going to be a slow.
Hey,
slow
Cassie,
drink.
I'm sure it's good. You just need someone with a more distinguished palate. That's the problem.
I know. She drew a short straw, but hey, I make up for it in other compassionate ways. I'm just supportive husband. Man, so we always go over our drink to talk about Cheers for Charity. I want you to bring back up your charity that we're supporting tonight.
Yeah, Walden's Puddle. We talked about that last time. They are an organization that takes animals that have been injured and they rehab them back, and they try and release them back into their wildlife environments. That's their goal. They're not trying to they're not trying to domesticate animals. They're trying to get them back out, and rehab them, get them back out, and they do a really nice job, I think. So
I think it's great that you brought them up. And what's really interesting, since you brought it up last time, I'd never heard of it before. But in our community, we have a local Facebook group for all the houses in our neighborhood. And someone posted about it because there was a baby deer that was limping. And they said, reach out to Walden's Puddle. And I go, I know all about him. So it felt good. It felt good. I felt like I was more connected to the charity offerings in Nashville. Made me extremely excited. I do want to briefly talk about our sponsor tonight is Active Spine and Joint Center. When it comes to initial onset tendon pain and rehabilitation, Active Spine and Joint Center has been specializing in this for over 10 years. Here to help you with all your tendon rehab and strengthening needs to make sure that you are back feeling the best you can, staying active, and getting as strong as possible. So Dr. Kindred, I can't wait to get into this topic of tendon pain. This is when we get real medical nerdy about this from the science perspective, it gets very, very challenging. But I think clinically we can talk about it in a very straightforward way that can really help a lot of people. But something that I find that is very challenging, and we hear this all the time, is individuals will say, and especially our listeners will say things like, man, I've just got some bad tendonitis. And then they have preconceived notions about what that means. So they'll almost in their mind's eye already know in their eye what the physician's going to do. Like, oh, it's just tendonitis. I need to get this shot. Or, oh, they're just going to tell me to just not do anything. And I think that we're at a point now where we can talk about those complexities, but still keep them simple, but to give some insight into the physician side of things on what some of the differences are, what the options are, and what individuals may go through. So I'm hoping that this is an incredibly enlightening conversation for everyone. But I would love, Dr. Kindred, if you could just start us off by just explaining what exactly is tendonitis.
Sure. So all of our muscles attach to bone through a tendon. Okay. And I think probably most people know that. But so each muscle has a tendon, and the tendon attaches to a bone. And so as we are moving, doing any type of movement, we're relying on those tendons to be able to move the bones, to move our body. And so as we do that, those tendons are working and because the muscles are working. So there's forces being put through those tendons. So the more work we do in the more, whether it's walking or whether it's running or whether it's swimming, we're putting force loads through our tendons. Depending on what type of exercise you're doing, specifically things like running, we're putting multiple loads, multiple times our body weight through those tendons, which is different from like a biking where, we're not putting the same amount of loads because we're not coming down with all of our body weight slamming into that thing. So that's why we talk sometimes about impact versus non-impact and the difference. We're talking about the loads that we're putting through those tendons. So when our tendons are very good at adapting and changing over time, but they're not good at changing quickly. And you jump in any time, Jason, on this, but they're not good at changing quickly. So one of the things that I'm sure both of us see all the time is patients who decide that I need to get more active. And so they go out and they try and run 5 miles off the bat. Well, you can imagine the force loads we're putting through that tendon. And tendons don't like quick changes like that. Big changes in loading does not go well. And so when we talk about tendonitis, we're implying that there is an inflammation going on within the tendon. And when we have an acute inflammation of a tendon, which oftentimes you'll see when you have an acute tendonitis, usually it's red and extremely painful. But lots of times we have patients come in, I'm sure both of us do, that say something is a tendonitis. You say, when did it start? Oh, it's been going on for 2 years. Well, tendonitis does not go on for 2 years, right? That's a different animal and a different picture altogether.
Yeah, I think that's great. I'm going to bring up that picture now to talk about that, and we'll allude back to it in a little bit. But I think that's a really good summary for basically the pretense for everything that we're going to discuss. I really enjoyed how you started out by saying that, look, tendonitis by definition is medically to us is a very specific thing. It's an acute event where we really overdid it in that moment. and there's going to be a clear, obvious swelling event. That is different than, say, pain in the same area when I poke or prod where one of my tendons are. And I think that's the big take home there. And I really enjoyed how you explained the idea of load. And that's still really confusing to a lot of people. So I'd like to take a minute and us both talk about that a little bit. When we think about an activity like running, where we are going through repetitive, almost mini jumps repeatedly. So we can call that like a plyometric event. So you're taking one leg, jumping into the other leg, repeatedly doing that. We take that for granted sometimes, not understanding exactly what's occurring there. But really, the tendon's role is the muscle itself is going to create that initial force. The tendon's then going to save it up with its reaction with the ground. And then its job is then to help release that back to repeat that activity to make it efficient. That's why we can do it for long periods if we do that right. But depending on if we do it even harder, like Dr. Kindred just said, that's when we think about activities like really explosive jumps and these bigger endeavors. That's where when we use the math, we can get to that number, like he said, load. So basically, just think of the more effort, the more strength, the more times you do that repetitiously, that builds up to a certain amount. And then if there's a threshold that we are trained for, and I loved exactly how you explained that as we do it slowly and repetitively over time, slowly increasing and getting stronger, it goes really, really well. And the collagen, the stuff in the tendon, are just think of it like our muscles and our tendons get stronger, our bones get stronger, we get healthier, and we can keep doing that and build up resiliency to that. But it is when we go from 0 to 100 real quick that things do tend to bark at us. And when they do, that's kind of the uncovering process, because it's really important when you see someone like Dr. Kindred and you walk into the office and say, oh, I have this pain and it's over one of your tendons. So where that muscle attaches to the bone in any of that area of the body, oh, hey, it's here. Let's see what's going on. That's when we're going to dive in to try to find out clinically, okay, well, which type of tendon-related issue are you dealing with? Because we actually treat them all completely separately. And I think that's the part that doesn't necessarily make the most sense to the average person. They think that all pain over a tendon is treated the same because the experiences they've seen from their loved ones.
So another thing that's important there is it's so we see tendonitis in patients who go from 0 to, really, really quick. We also see it in well-trained athletes when they decide to add something to their workout that's not normal. So all of a sudden they start doing a big heel workout, and they don't do a little bit, but they do a whole bunch of heels in a workout. That's going to throw this tendon over, right? We're increasing those force loads dramatically, or we're going to do speed work. And we're not just going to do a little bit of speed work, but our coach gave us a huge speed workout. Even though we're not used to doing it, we got to get through it. So that will do it. And also distance. So if we've been running 6 miles, we're like, well, I'm just going to go do this marathon. I've done 6. Those are things that we're dramatically changing the loading of the tendon, and not just the amount, but also the way we're loading it. Because when you're used to running 6 miles. Now you're running 24 miles. I mean, the biomechanics and everything is going to change over that 24 miles. And so our tendons just don't do well typically with that type of change in a variable all at once.
Yeah. And I think the running example is really good, because when we think about our tendons, we really have a few different types to think about and how they're going to react to certain activities. So for example, like the Achilles, what I really enjoy that you just talked about is that idea of instituting hills, because what that's going to do is going to change the angle and the amount of force that goes through that portion. And that's going to really ramp up just the effort that's happening. So if we think of the body as a team sport, a team activity, and break up each facet. So say we've got one for the Achilles, one team member, there's a foot, one's the knee, one's the hips. And we think about this, and then now we go on a hill. Well, the one that's carrying most of the weight now does shift down towards, say, that Achilles. So now if we're doing that over a much longer period of time, that's an easy way to trip off that Achilles pain.
Exactly. Now, another thing that I'll mention, and again, hop in here anytime, Jason, but as we do this, and even if we're doing it correctly, we are creating micro trauma in our tendons over time. And so I think no matter, and I think there is some genetics that play into this. I think that how active we are and what type of activity we're doing and how we're loading as far as how we're ramping up and all those things play into that. But all of us are doing micro traumas to our tendon over time. So sometimes I have patients who, if I look at 100 tendons on ultrasound, I'm going to find something wrong with a lot of those tendons, even though the patient's not having pain. But I think that's important to point out that that's not necessarily a problem, because micro traumas are micro traumas, and they're not always something that needs to be addressed as far as the micro trauma itself. Would you agree with that?
Yeah, absolutely. Especially if we recover well, right? So that's by definition, that's what we're looking to do, is create those micro traumas. But if we do recover well, that goes a heck of a lot better. But now in the case that I really enjoy that you brought up is the idea of the individual, that what are some of those other components where maybe it doesn't go so well for them, and now things start to show up. Or I really want to dive into the ultrasound example you just brought up, because as you know, I've gotten into diagnostic ultrasound more and more over the last 3 years, and we've seen a whole lot of that as well. And I think that that's a really important topic to discuss, that we can give some really good information on how valuable that is. We did have a question come in, and Alan had asked, so by definition, would you say, Dr. Kindred, that tendonitis in its specificity is only acute, not chronic?
Yes. So this is important to differentiate too. So we have tendonitis, which is always acute. It's always inflammation, and I would say it's always painful, acutely painful. And when I've seen true tendonitis, it is red and it is miserable. The good news about tendonitis is it's oftentimes pretty quickly able to be reversible, because it's an acute event, and lots of times it can go down. Now, when I have a patient who comes to me and said that, I've had this pain for 3 years, it's in the tendon. So we differentiate that in the sense that it is a tendon problem, but we don't call it a tendonitis, implying the acute inflammation. We call it a tendinosis or a tendinopathy, meaning that we have change in this tendon, but the change is chronic, and that chronic change in the tendon is causing the pain. So it's not the acute inflammation that we think of as in an itis, but there is pain coming from the tendon, but it's a tendinosis or a chronic change in that tendon.
I think that's great. Right now I have the tendinopathy picture up on the screen so they can see that. What they're seeing is that animation of, you have the muscle, you see the tendon. There's that change in colored area where you can see that tendon is not the healthy tissue that is like the other, where all the fibers are running the exact same way. It's a little bit more disorganized. But I think the interesting part that Dr. Kindred just alluded to is you can have perspective where that is also painful, but you can also see that on imaging and it not be painful. And that's a topic I want to go back and forth on for a minute, Dr. Kindred, if you're comfortable doing that. Let's talk through a couple of scenarios that you see when that is not painful, but someone's in really pushing for a scan right away.
So this is how I look at a tendon. When I see a tendon and there's no pain, but I see big areas of tendinosis, or some of them call it scar tissue, because normal tendon tissue is this nicely tensile, and it's able to stretch, it's able to move, and you can see it on the ultrasound. It looks nice and healthy and striated. So as we start to get these micro traumas, then those micro traumas oftentimes end up with this disorganized pattern of we'll call it scar type tissue, for lack of a better term, scar type tissue that fills in there. And this is in a micro level. So, these tendons are big, huge, and we get this little area of these micro scar type formations in there that we see with ultrasound. That doesn't necessarily mean that there's going to be a problem, but as those get more and bigger, then I think it's a setup for a problem. So I always tell patients it's like kindling on the ground, ready, and it takes a spark to get that thing going. And once it's going, it can be hard to put out. So again, this is different than an acute tendonitis, but that tendinosis is a setup for pain. It doesn't mean we don't know when that pain's going to occur, but that's why doing big overloading activities is a surefire way to do that spark and get that thing going and fired up. Would you agree with that, or you add to that?
Yeah, I would say that when we see that tendinopathy, I think what's so fun about this conversation is we see it. I would say we probably share maybe 30% of the cases that would probably come to you right away or me right away that may not know about all the different avenues of how you could seek healthcare. And we probably see about 30% that are very similar. And then I bet the rest, we're catching them at way different timelines when we actually see them. So for example, a lot of times we'll catch cases really early on. And if we wouldn't put the scan on there, or say before we had diagnostic ultrasound in the clinic, if we wouldn't have done that and there wasn't the inflammation, we basically would categorize it into a few different categories of how they're presenting. And for our side, when we're doing the rehab side and the getting it strong and getting them recovered, the big thing that we want to look for and to be able to diagnose is it actually the tendon, or is it that area around the tendon, or is it something entirely different diagnosis wise? So for example, at the knee, so often people think that they have, or we've even had many refer it in and they'll say, hey, they've got a patellar tendon issue. And then when we do the evaluation, in the science side of things from the sports med side, that's pretty clear when that's going to be a patellar tendon. Evidence pretty strong that we're going to see that that's going to be in a jumper, they're an athlete, young basketball player, younger age, aggressive, big activities they're performing. And a lot of what we'll do is we'll challenge that tendon. And one of the ways that when we're doing the rehab side, we can categorize it based on how it responds to certain exercises or activities. So how we classify it is on the side where we're going to be doing lots of movement testing for them and activity testing, is that if it's a tendon, the more load we add, exactly like you just explained, the more angry it's going to get. And what we mean by that is if they're an individual, then say they have that Achilles issue, and we notice it's the type that when we get them on that incline, that the pain gets worse, that the harder you load them, like say that they were trying to do a calf raise and they did it on both legs and said, oh yeah, that's not a big deal. They do it on one leg, like, oh, that hurts. And then now we took them and said, hey, well, let's just jog a little bit. And initially maybe it hurts, but then it gets a little better. But if we put them on hills and ramp it up, they instantly notice, that ramps way up. Or say in the knee, we'll try to triage that out and say, okay, well, let's load that tendon up a lot and see what happens. And if they can tolerate, if loading up the tendon itself doesn't make change to those symptoms, instead maybe it's kneecap or under the kneecap related pain, they're going to test completely differently on some of those activities. So where's your head go with that?
So
was that too vague?
So tell me, when you so how would you differentiate that from paratendon? So in the tendon, that's how you're saying that's how you know that it's in the tendon, right? By loading it and it's getting worse. But how would you differentiate that from the other?
Yeah. So if we're talking about the tendon itself, so we know that that's going to be very indicative, like load response difference. So if we hammer them right then, and they're also, depending on what activity we take them through, they'll have a little bit different response. So if we take them through, say, if it is the patella, if we're going to load that up on a special type of knee extension, so we're going to try to make a really high level of effort, typically at about 70% of the max that they can handle. What we'll notice when it comes to the tendon itself is that if they do like a long isometric, so one of those treatment techniques that we will use, that they will be able to tolerate that really well. And in session, they'll actually get massive pain reduction if we're doing something like an isometric. And we'll see that gets a lot better. But if we then do the same thing and say, all right, well, now we're going to test it again. We're going to test that same case that has been told that it's their patellar tendon. But now we load that up and they're like, oh my gosh, my knee is miserable. Like that's really, really terrible. That's typically not going to, that tendon's not responding. So that's more of like, oh, they're getting pain at the actual kneecap. Does that answer that question a little bit better?
Yeah,
as it's related to
yeah, that's good. That's good.
Yeah. And for us, that's crucially important. Go ahead.
Yeah, that's good. It's good to, this is why different perspectives of like you said, when you're seeing patients versus when I'm seeing patients, although we send patients back and forth, the type of stuff we're doing and our paradigms are different. And I always tell patients that when I send them to you is you're coming from a different perspective, and that's what's good about it. I mean, you're looking at the way they're moving, you're looking at these things, and And while I do a little bit of that, I certainly, the perspective you have is very valuable on that. So that's good.
And especially those acute tendonitis cases, they're in our world. That is, how quickly can I refer that to Dr. Kindred? That's what that cycle is. When it comes in, it's red, it's swollen, it's flamed. It's almost a race to how quickly can we say, all right, well, we know what the right action step is here, because for us, either we're going to have to, wait to calm that down, or we're going to assess the situation. But typically talking with the individual, that's going to help us differentiate how, what's our timeline? What's the activity like? Because the big thing is, if it's, say, like an Achilles tendon, one of the toughest issues with that is if we go back and say, look at how that was managed in the 80s and look at some of the expert researchers that we look up to a lot, is that, the data basically stated that what was the common medical treatment would have been, all right, well, you're going to rest it because your Achilles hurts now. We're going to rest it a lot. We're going to ice that. We're going to take our anti-inflammatories, and then we're just going to wait that out. And what we've learned so much in the last many years is that really those tendons, the way that their nature and structure is made, they respond and heal best when we give them the right amount of strengthening and stimulation. So if we just rest it, it actually changes the stiffness of the tendon. And to not get too sciencey, but the reality is, we all know, like you just said, that the muscle is attached to the bone by the tendon. We're aware of that. Well, the next step of logic there is the tendon's going to help transfer those forces, which is really, really important. But if we change the stiffness properties of that, we're actually going to have more pain. We're going to have more guarding. We're going to change the activities we do. And if we let that go too long, we'll actually see that if you measure, say, calf circumference, they're going to actually start to lose muscle mass there. If they go with that very long, they'll lose that function pretty quick. And the reality is that makes that an absolute dadgum nightmare to get back. And that's what we see a lot of times, is they're stuck in a tendinopathy nightmare because they had got that advice that was cutting edge in the 80s, but maybe isn't the best for where we're at now, because maybe they didn't get to see someone educated in it like yourself, or they just had a predisposed bias that, oh, well, when my dad went, they just told him to just wait it out and ice it, etc. So that's what I'll do. And that's what's really tough, is to get full awareness to everyone that the science has updated so much, and we've seen so much great success in the last decade, that the options are out there for you. Don't be shy to see a great clinician that can help guide you on how to get through that faster. And the sooner you get to them, the better.
And one thing that I think is, goes back to what we were saying earlier, is in the 80s and even into the 90s, we were treating a tendinopathy like a tendonitis, right? We're saying, no, we just got to let this thing cool down. We got to use anti-inflammatories. We got to ice it. We got to rest it. That's what we do for a tendonitis when it's acutely inflamed, but we're not dealing with acute inflammation. I think that's the difference, because it doesn't make sense if something's not on fire and you're hosing it down. It's just not the right treatment for it. So we need to know what is the problem here. And it's that the tendon has dysfunction, in the sense that if you think of scar tissue, you have healthy tendon that's working, then we have scar tissue that's in that tendon. Letting that rest isn't going to get that to go away. The only way we're going to get that to go away is by stressing it, right? And by helping the tendon around it, and then hopefully get overloading it to a point where we can tell the body that, hey, we got to come in and reinforce this tendon. We need to get this thing working and using it. And we can't just do that in a cookie cutter fashion, or because, and this is another thing we've learned through our research, I think you say, is that if we just start hammering out patients on single leg squats, we're going to overload this thing too much, and then we're going to end up in a sticky situation as well. So it has to be this graded overloading and then a continued overloading. And you can probably speak to that even more than I can.
Yeah, it's actually a big issue, not a small issue, that so much of the rehabilitation world has been forever. There was a time where we just thought, we just want the formula, right? Everyone just wants the solution. What's the sheet that I need to hand them? Because if I give them the right sheet and give them the right exercises, they go do it, they're better. And then and it's efficient. I can see a whole lot of people at one time, and we can do it that way. And it's exactly what you just said. It does not work that way. That we can't just say, here's this exercise, go do it. So for example, we have some good evidence for doing specific protocols for that research studies have been done, really good high quality studies on, say, like an Achilles tendon, what you would do to rehab that when it's in bad shape with a bad tendinopathy. But what'll happen all the time is they will say, well, I can do close to that, right? So I'll do something similar to that. So I'll just say, hey, go do this, go do 3 sets of 10 of this at home, do that for a couple weeks, come back, let's see where it's at. And they're arguably worse or no better, or even stretch that timeline out dramatically further. And it has to be that one-on-one connection to find your exact dose that's right for you. Like there's a therapeutic dose that's right to get the rest of that tendon and to get the muscle coordination back and to correct all that good tendon stiffness and things like that we talked about earlier. There's a right dose for you, but you've got to have some guidance to find that sweet spot at any given time, because it's way closer like braces than it is like here's the recipe to bake the cake. And that's the difficulty, I think, for most to really grasp. And it's also a frustration I guess everyone in healthcare would share, because it does require that expertise role to get it better consistently.
Yeah, absolutely. And, this goes back, if I had a nickel for how many patients, I send to have something done therapy wise, but insurance is prohibitive or the cost is prohibitive. I mean, and that's a real problem with our health insurance and with our whole medical system in the U.S. It really needs to be addressed, because we're not enabling true cure from disease when we're not opening pathways to be able to get rehab like that. And that's a real downfall, because it really is cost prohibitive sometimes for patients to come in to see you or to go to a physical therapist. And that's a problem, because it's really hard to treat these tough tendinopathies, through an office setting. And we get stuck doing that, trying to do that all the time. And it's certainly not a best case. I mean, the best practice or, evidence-based stuff. It just isn't. And that's a real problem in sports medicine, I think, probably throughout the United States that we have in having that limitation.
Yeah, I think it's a real struggle, because we were talking to Dr. Seaman and Dr. Scott Jordan about this exact topic that you alluded to that is so challenging, is that overall healthcare, let's take it one step further from where you just took it. If I'm someone that's trying to get healthy, that's, maybe barely survived their 30s and 40s, just hanging in there, parenting, work stress, life stress, maybe they haven't had the 30s the way that they hoped they would go. They've gained some weight. They're not where they want to be. And now they say, you know what, dadgummit, I used to run, I loved it. I'm just going to get it back. Like there's some catalyst that happens and they're going to get it back. And nothing's worse than that moment where if you looked at it and mapped it out, they're on a pathway to change their life, to change their body chemistry, to crush chronic disease by getting their life right. And then now they're stopped in their tracks because they've got this miserably painful Achilles. And then now they don't know where to turn. Or if they did, maybe it's not the right time for them. And at Axis and Joint Center, the one thing I can say that I'm extremely proud of is that in those cases where, cost is an issue, have the most flexible options to be able to work with them to make that work. Because it is such a burden, and so many stories we hear all the time, exactly like you said, that they're going to get this major bill or it just doesn't make sense that they can't work with them. It's like eventually we need that to change, because especially from the healthcare payers, because on the back end of this thing, when we get to the last third, fourth of our lifespan, that's when the medical dollars are dramatic when you look at it from that perspective, from fiscal responsibility. And so much of that could have dramatically been changed at those instrumental times if it came down to something as simple as the Achilles is miserable and they say, to heck with it, I wasn't made for that anyway. And then they just give up, when that's not what we want to see happen. But gosh, you could paint the scenario where someone's not maybe as up with the research as yourself, would then come in to some clinic that maybe they don't ever see tendons. Maybe, maybe they only do in chronic illnesses. And then they just say, oh yeah, ice it, rest it, elevate it, and using maybe, a protocol that isn't the best or didn't get the right referral, but maybe said it as what they felt was very clear, but the patient somehow interpreted it as, oh, I'm doomed, I just need to go rest it and not worry about it. That's the lose-lose there.
Yeah. And I think a lot of times patients do feel like, especially if they've had a chronic tendon thing going on for a long time, they feel like that they're just they're that's their fate, right? That they got to deal with that thing the rest of their life. And it does. It stops a lot of people from being active, which is so bad. I mean, I think that there's definitely ways to get them back active again, and and I think there's ways to keep them active during the
Absolutely.
treatment period for sure. Even if we have to switch up their routine or switch up what exercises they're doing or switch up, what activity aerobically they're doing. But I think it's so important to stay active that it trumps everything else. Once you get out of the habit, especially for people who you're talking about that are just getting going, that is just like dousing that fire and putting it took so long to get that thing, they got it going, they got that thing ablaze, and just dousing that fire, and it's so hard to get it going again. So I believe so strongly that to keep people active is the most important thing we can do, and then trying to keep them so that pain is not going to keep them out of things. Because I have patients all the time say, "Oh, I can't be active. I can't do activity exercise anymore because of such and such. Whether it's arthritis, whatever." But it's like, no, that's not the way to look at it. And I think we as a healthcare system have kind of put this in people's minds, whether they've had a diagnosis at one point or that, how many times do you get told a day that, "Oh, my ankle, I got bad knees," or "I got bad ankles"? I mean, what does that mean?
Yeah.
What does that mean?
It's so unfortunate when we hear that because where it's coming from. It's coming from a place of, I've given up on it. And that's what's unacceptable, because we know that's not how it is.
Even more unfortunate is when it comes from a doctor, right? When a physician told them they've got bad knees, and so you can't do that. I mean, to me, it's like, no, those are the worst things to be telling people. I mean, even if everyone may not be made for running, but certainly we don't tell people that you can't do it because of your knees or because of your ankles. I mean, gosh, that's a terrible thing. And I hear that all the time, that doctors have told them this, and now it's 20 years later, and they were told that 20 years ago when they were running all the time. And now it's just like, oh man, it's such a tough path back at that point.
It is, because a lot of times when they're hearing that message, what is so hard as a person to just wrap your head around, just putting yourself in anyone's shoes in that scenario, they're typically at a pretty desperate point when they're saying that. And they're at that influential phase of like, all right, what's the action step? I'm gung-ho and ready. And if you literally just pull the rug out from under them and just say, yeah, you're just going to have that pain the rest of your life. Like we heard that this week to someone that had an injury a year ago, and they're like, yeah, well, that's just going to hurt forever. And it's like, it's so hard, because if they get that message at the wrong time, then they're just going to go ahead and just put it in the back of their head. It's going to change their decision making forever.
It's almost like it gets hardwired in, right? It's like it becomes part of that program up there, and they just have this in the back of their mind that, hey, I have bad knees, so I can't do such and such. I'm never going to be able to do such and such. And yeah, it really is tragic, and it's something we have to change that mindset, because it's very dangerous. It's very dangerous for people's long-term health. And again, our healthcare system is set up for short-term, but it's not set up looking at the long-term. And that is really something that I don't know how to fix it, but it's got to be fixed. It's got to be something that changes.
Agreed. And I think that's where the increased education for all healthcare providers, that's where it's key. But I also think it's so important for all of us with our own individual expertise to do our best at staying in our lane and referring to other experts, because medicine has gotten so hard. I mean, the reality is, pick a condition, that the evidence base is so thick now. You just keep up with any given set of topics, let alone all of them. So sometimes it gets tough when you're used to being an expert in one facet to then, accidentally say something because they're going to hang on every word because you're such an expert in X, Y, or Z topic. And then maybe that's not the exact best advice at that time. That's what's really hard. That's why I do my best to make sure, if it's something that I don't feel I have a really, really good knowledge base on, that how quickly can we get them to the right person that can give that opinion? Because that would be the worst thing that we could ever do, is jump out the gate with some insight into something that I caught a few tidbits, or worst case, I'm given back from the education that got 12 years ago that's so far outdated that, who knows? So that's always my worry. And I just think we need more to keep that top of mind. we did have a question just come in from Alec, and he wanted to know, do different tendons in different areas act differently, or do they mostly act the same? I wanted to jump out with this one right away because I think it partners back up to the question that you asked me earlier that we moved on from pretty quickly. When we talked about that, all right, what's the difference between, say, that the actual tendon that's really painful versus maybe that outside portion of that tendon that's painful, like, or the sheath itself, that the area of certain tendons that helps produce that fluid to lubricate and to keep it happy. What's the difference between those? With tendon pain, when we are treating that has very classic symptoms. It's going to have that morning stiffness. It's going to have that with the more plyometric, or what we'll say, that's a real sciencey term, that load perspective. The more load we put to it, that all the storage and release activities where it needs to store up that activity, that energy, and then release it to do something ballistic, those things are going to make it more painful, and there's going to be that stiffness. With that peritendinous, where it's that more outer side, we think of that more like our compressive or our friction-based irritations, that there won't be a whole lot of weight and load behind that, but it'll be lots of repetition, lots of actions, big motions, that kind of thing. That typically gets called that overuse. That's typically how we look at that. So depending on the area of the body, like certain areas, we talked about that certain tendons have that sheath. Well, those are at different areas of the body, so they're going to respond a little bit differently than an area that maybe doesn't have that sheath, a traditional sheath like an Achilles. Jeff, do you want to take something from there?
No,
I can run too.
I think you covered that.
Yeah, and I can run a little bit more. The last couple tidbits I wanted to say about that is that depending on where it's at, like if it is the front of the knee, or if it is in the Achilles, we use those because those are pretty classic ones that we hear about all the time. But we can go elbow, lateral elbow, so our tennis elbow cases, we're going to be differentiating in those. That, believe it or not, that there's a difference between if it's happening at the muscular end, or if it's on the actual tendon, or if it's actually at the bone. So depending on the activity, sometimes it is going to be very important to say, all right, well, maybe it is, you need to cool down on the movements for a little bit, but we still need to do things that are going to help strengthen it. So to give a little bit more insight to the rehab side, when we're thinking about it, one of the things that's so important, why guidance is very valuable, is because when you're doing special strength training, and we have different terms for rehabilitation, there's a whole lot of them, but the reality is we just need you to get back to the things you love and the things that you want to do without pain. And when you have a tendon, like I'm putting up on the screen right now, where you have that area that's not as healthy, when we look at that under imaging, the reality is, if you see on the left side of the screen, there is that donut there. And one of the theories by one of the great researchers of our time, she alludes to it as what they call the donut hole theory of tendon pain and rehab. The reality is, for us, and Dr. Kindred will be able to allude to this a little bit better for procedures for the actual injured portion of the tendon, but the reality of the situation is, when we have that area of the tendon that's not healthy, or like Dr. Kindred would say, that scar tissued area, from the strength training, no matter what you do rehab-wise, everything that's going to get affected is going to be the donut portion, the outer portion, the healthy tendon part. That's going to get a lot stronger, and the muscle's going to get a lot stronger. One of the cool things that we've learned in the last 10 years is that they did this very special type of ultrasound sequence on those tendons, and they found that if you take it and were to say measure, just think thread for thread of that tendon, that even when you have one of those bigger tendons from the tendinopathy, you actually have a lot of really healthy fibers around it on all of them that they measured, that you can have really healthy on those chronic, or they just built up that pain that you've had for 2 years over time, that you actually have a lot of healthy tissue around it, but you need that to be its best. That's got to be the strongest. And that's what we've got to do better as a healthcare community of educating about. But the way that we fix that, and the reason the guidance is valuable, it needs good, heavy strength. So you need the guidance and the confidence to make sure that you're able to train that from strength training, because the strength training with the heavier weights, the heavier activities, are really low load as far as to the tendon itself. It's really those springing activities, that really load up the tendon itself, not the actual strengthening and the heavy weights. So those things that you'll notice, like at Active Fine Joint Center, you're gonna get to work pretty hard on those areas. You're gonna work hard, but that's gonna help get those muscles to coordinate better, to make sure that your mechanics with the activities that you're doing has better endurance and can last a heck of a lot longer. And that's how we're gonna approach that. But again, it's like that braces phenomenon. You've got to find what's the right amount of strength and effort today, but that's a moving goalpost every several visits if it's done right. So you've got to constantly be moving that up. What you're doing that first couple days, or if someone's using a bunch of TheraBand, those stretchy bands to do rehab for something like an Achilles or a knee tendon, that's maybe for an acute tendonitis, if it was truly that. But for these real tendon issues, that's not gonna get us anywhere.
Yeah, and it's important to know that tendinopathy rarely needs more than exercise, right? I mean, these things respond really, really well, even though it can be frustrating and it can be challenging to go through it. But I mean, how many times do I hear patients who come to me with this type of problem, like, I already did therapy and it didn't help? But it's like, well, I'm just not convinced that we did it correctly or did the right things, because and there are other options for this, but most of the time these things get better if you're getting the right type of rehab and therapy and an overall assessment. Is something else going on that's causing this tendon to be overloaded? So yeah, I think that's important to state, is that tendons respond well to rehab, and surgery is just very, very rarely needed in these types of things. Even though it's done a lot, it's rarely needed.
Yeah. Can you talk a little bit about 10X? We actually had 3 questions come in, and I want to make sure that we get a couple of these answered. For sure, I would love for you to be able to touch on, Aaron wanted to know how NSAIDs play a role in tendon pain. And Mitch had ended up asking, how long is recovery time between a true acute red swollen tendonitis versus tendinopathy? And I would love for your take on both of those. And I'd love for you to talk on 10X too. So how about I just give you a playbook here of 80 things I'd love for you to comment on in order in the next hour. I don't know why I went that approach, but I would love your take on all this.
So NSAIDs in an acute tendonitis are appropriate. NSAIDs in a tendinopathy, even though they're used often, I don't think there's much, if any, evidence. Jill Cook, I know, has said that her feeling was ibuprofen maybe sometimes can be helpful, and there's a lot of reasons for that. But overall, we don't, even though they're used all the time for tendinopathy, most of the time not that effective. I think we've come to that consensus. So they can help with pain, but they're not helping heal the issue. I think we know that with certainty. Okay. The second question there, what was the second one?
I think it was between the timeline difference between acute actual tendonitis and tendinopathy.
Yeah. So acute tendonitis is usually you do something one day, the next morning you wake up and that thing is killing you, right? That's what a tendonitis looks like. And so it's we're looking at like days. Where tendinopathy, recovery wise days. Oh, recovery wise.
Yeah, sorry. I reread the question now. It's all recovery. It was a recovery question.
Yeah, so depending on how that treatment is done, if you're tendonitis, if you're taking anti-inflammatories and you're going to just give it a week, I would say a lot of times it's going to settle down quite well. Now, I do see patients who come in and it's rip roaring and it's been going on for a week, and we inject it, and then that settles it right down. And injections can be helpful, sometimes for a tendonitis and acute tendonitis, but not always necessary as well. I think that sometimes we don't need an injection for that. Whereas a tendinopathy, we're looking at a longer, prolonged period, because we're trying to rearrange tendons, right? We're trying to get a tendon healthier, which is not something that happens overnight, and it's not something that doesn't happen without work. It takes a lot of work to get a tendon to rearrange and to become stronger and to reinforce and all those things we want to have happen, and only can happen with loading. So much different treatments for the two things, and that's why it's important to differentiate the two things. And it's not that difficult for someone who deals with them a lot. I mean, those are things that are pretty cut and dry. So 10x in patients who have gone through rehabilitation and we can't get the pain to dissipate in a tendon that has scar type tissue in it, or the tendinosis or the tendinopathy tissue that we can see on ultrasound. There is a procedure that we use where we go in with a little, it's like a needle tip, but it has an oscillating end to it that's oscillating at a very high frequency, and it's emitting an ultrasonic wave to try and break down that scar tissue. Now, what they're saying this is doing is it's the ultrasonic wave is breaking down the bad tissue and it's leaving the good tissue. So the wave is at a sequence where it's not going to break down good healthy tissue. Okay, and so we're putting this in with ultrasound to guide it into that area of tendon that we see is abnormal or is the scar type tissue, and we're taking that portion out, or we're breaking it down and then taking it out with this little needle tip procedure. This was first used in breaking down cataracts at the Mayo Clinic. They were using this thing to break down cataracts, and then found that, well, we can see these areas on tendon on ultrasound. I wonder if we went in and try and break them down, if that would make a difference. So again, to emphasize again that this is not something that's needed often, but in remittent cases that just we can't get them to go away, and that can be plantar fascia or patella tendon or lateral epicondylitis, or like a calcific tendonitis in the shoulder, or in like a proximal hamstring issue, or an Achilles that just we can't get better, then this is a procedure that can be useful. It's much less downtime and much less involved than a surgical procedure, which they do where they go in and actually open it up. You're asking for a lot more recovery time and immobilization. So this is a way we can do that in a faster, less invasive, and fairly successful. You know, nothing's 100% successful, and it's, again, emphasize again that usually something like this is not needed, but it is a good option to have in the toolbox for cases that just are not turning a corner, and we want to, we need to try something else, and surgery is our last resort. This is a not a very minimally invasive procedure that can be helpful.
Yeah, I think that's really cool, because what's so interesting is that as the science progresses, we have so many, we always raise way more questions than we have answers. And I think that's when we get real sciencey about it. It gets really challenging. And, the more we learn about that area in the tendon itself and some of these other challenges, there's no telling what we might uncover as to even more understanding why that is so successful in the cases that it is. We had two more good questions come in, and then we'll wrap it up. But Alan Bickmer had asked, can a chronic tendinopathy become acute?
Yeah, that's a really good question. So I think what I was talking to earlier is when we have these portions of the tendon that are scar-like, then that's a setup for pain. So we do something to overload that tendon in a way where we can make this an acute on chronic problem, right? So it's actually not a tendon. It's not a tendonitis, even though we may have some acute inflammation, but the underlying issue, or the bigger issue, is this chronic tendon that now is activated, so to speak, and it's giving you the pain signals because we did something to spark it and to get that thing now on fire. And
yeah, exactly.
Go ahead and say how your answer to that too. I'd be interested to hear.
Yeah, I think that was really great. I mean, the reality is when we get down to the cellular level, I guess I'm not an expert enough in it to be able to answer that without getting too medicalized. But the reality is the way the tendon operates, it's at the cellular level that all of this action occurs. So in the area of the tendon, when we have good strength training to it and we're rehabbing it, it'll do a great job. And it'll respond, but it responds to those forces that we put on it, keeps churning that healing and strengthening process to be able to share the load. So it's almost like if you have 4 family members and 2 of those family members in the house are just never helping with dishes, never helping around the house, and that mom does everything, and then dad only helps out, with what he can, and you've got 2 other fully capable teenagers around the house not helping. Mom's going to be miserable. Dad's going to be pretty miserable from that scenario. But if we all pitched in, we could have it done in a tenth of the time. But it's almost the exact same thing from the rehab side. But when we trip it off acute, so when you have that activity where it went dormant for a long time, you had no idea you even had this chronic tendon issue there. But then you had that big activity that really overdid it, and that set it off. When that occurs, we've then now established that the tendon and just the whole area was not ready for the actions we asked it to do. So now we have to make sure that it's ready. So now everyone on the team has to play really well. And that's when we have to step in and help make sure that everything gets where it needs to in a proper order as far as strength goes, and to get it back and to be diligent and to not give up on it. I think that's what's really important. And if you get with the right help, they can help guide you on exactly how that progression is going to go. And the goal is to graduate from the program as soon as possible so that you can then maintain and self-run that strength plan. But there's just certain phases and hurdles that are really challenging that I do understand why certain people just say to heck with it and feel like they give up on it years ago if they didn't get the right guidance. Because if you did, say, 3 weeks or 4 weeks of therapy and none of it was the right amount or the right effort level to get to actual good tendon healing and recovery and good effort and feel like you're starting to make some progress, it's real easy to get disheartened and say to heck with it. But if you're with the right clinician, they should be able to project based on your full history of the things that you've been doing the last several months, what you were doing when it happened, and then doing a good thorough evaluation of what the state of the union is of all the areas around it. You should be able to predict really well what that recovery is going to look like and how much you can possibly do to keep staying active, because that's the number one goal. With a lot of these tendons, we can get them to warm up with the right exercises and such and get the pain to drop out to where you can complete the activity, but there's still a point that's going to be too much for it. And that's what our job is try to keep you active doing the things you love with doing the minimal necessary, but enough to get a therapeutic dose to heal and recover.
Yeah, absolutely.
We had one last message come in. It was from Craig Plank, and he said he wanted to say hey to the 2 best docs he knows. That's an awful humbling statement, so we really appreciate that from him. But Dr. Kindred, you got any closing statements?
No, that was good.
Man, I think it was great. I incredibly appreciate you coming on. I think we unraveled a lot of the initial topics related to tendon pain. If a lot more questions keep coming in, because they keep coming in, maybe we could even do a tendon pain round 2, but I've already got next topic in mind. Brother, thank you so much.
Jason's sitting in 80-degree heat. We got to get this thing over so he can go cool off.
Yeah, all right. So since you let the cat out of the bag, I don't know what's happening, but our thermostat was set to 78 when I came up here. And I would tell you it is not 77 now. That's what I would tell you. All right, Jeff, thank you so much, my man. Can't wait to see you soon.
Good talking with you.